So, hi guys, I hope you are okay. We've got five high-yield biochemistry questions for today for the USMLE Step 1 exams, through which we're gonna break down some of the high-yield concepts, so make sure to watch till the end. So we've got our first case here of a 5-year-old girl presenting with bilateral leg pain, muscle weakness, and growth failure. She cannot stand or walk without support, and the physical exam reveals a prominent forehead, aka frontal bossing and outward bowing of the tibia/fibula, and patchy alopecia X-ray shows like frying of metaphyses, and genetic testing confirms a homozygous loss of function mutation in the vitamin D receptor gene. And the question asks, what are the most consistent lab results about her condition regarding serum calcium, phosphorus, 25 hydroxyvitamin D, and 125 hydroxyvitamin D? And the correct answer is the decrease in calcium and phosphorus, while 25 hydroxyvitamin D is normal, and an increase in 125 hydroxyvitamin D. So this refers to a condition called hereditary vitamin D resistant rickets. Why is the correct answer hereditary vitamin D resistant rickets, and, for example, not rickets due to nutritional deficiency? So in hereditary vitamin D resistant rickets, there is a decrease in calcium and phosphorus, while the 25 hydroxyvitamin D is normal, and there is an increase in 125 hydroxy vitamin D. So the pathophysiology behind this disease: the vitamin D receptor mutation blocks 125 hydroxyvitamin D signaling. So although we have increase in the 125 hydroxyvitamin D, the body will sense there is a deficiency because the signaling is defective. So without the receptor function, the intestinal calcium absorption will not be effective, and we will have hypocalcemia, and renal phosphate reabsorption is defective. Also, we will have hypophosphatemia. The phosphate, we will lose phosphate due to secondary hyperparathyroidism, because here we've got like decrease in calcium, so the body will respond by increasing parathyroid hormone. So the parathyroid hormone will decrease phosphate reabsorption. So we will have hypophosphatemia. So this is the pathophysiology behind that. So here we've got normal 25 hydroxyvitamin D. Why is this? This is because the liver hydroxylation is intact, because 25 hydroxyvitamin D depends on the liver, and here the liver hydroxylation is intact. But on the other hand, 125 hydroxyvitamin D is elevated because there is hypocalcemia. So the 125 hydroxyvitamin D is not working, so the body will sense there is like not effective. So 125 hydroxyvitamin D here is increased. Also, it is increased, it is defective. So we will have hypocalcemia. So this hypocalcemia will increase the secretion of 125 hydroxyvitamin D, because also it is present, is not effective, so the body will keep producing more and more of it. And the key point here is the body overproduce active vitamin D to compensate, but it is useless without functional receptor. So we have to differentiate between hereditary vitamin D resistant rickets, so there is a resistance, versus nutritional deficiency. So in nutritional deficiency, the 25 hydroxyvitamin D is decreased, versus here it is normal because the liver here is intact, while here there is a deficiency, so the body is not getting enough vitamin D. And 125 hydroxyvitamin D is increased in hereditary vitamin D resistant rickets, because the body will sense there is a decrease in vitamin D, in active vitamin D, so it will produce more and more of it. Versus nutritional deficiency, this gonna of course be decreased, or maybe normal, but is not gonna be increased like hereditary vitamin D deficiency. So lastly, we've got alopecia. So it is unusual to see alopecia associated with rickets, but it's true. So alopecia is associated with hereditary vitamin D resistant rickets, but it is not present with nutritional deficiency, rickets due nutritional deficiency. And why alopecia? Because vitamin D receptors regulate hair follicle keratinocytes. We've got here resistance at the level of the receptor. So consequently, the hair follicle keratinocytes, which are dependent on vitamin D receptor for their regulation, is gonna be affected too. So to recap, so if you've got a vignette where you find increase in 125 hydroxyvitamin D associated with decreased calcium and phosphorus, as this is maybe the answer. Versus like rickets nutritional deficiency where the 25 hydroxyvitamin D will be decreased, and 125 hydroxyvitamin D which also will be decreased or is gonna be normal, but it is not, but it is never gonna be increased. Whether so the pathophysiology behind the rickets, whether it is due to hereditary vitamin D deficient rickets or nutritional deficiency, is the decrease in calcium and phosphorus, and consequently there is an impairment in bone mineralization and osteopenia. And so the characteristic features that we find in the children that have rickets from osteopenia, so bowing of the tibia and the fibula, so prominent forehead, frontal bossing, and outward bowing of tibia and fibula. So we've got a 12-year-old boy presenting with exertion-related chest pain, elevated troponin, and elevated ST segment on ECG, and lab shows high methionine level. And the question asks is which amino acid is likely essential in his case, and our answer is cysteine. So this is the methionine cycle. So this clinical presentation is classic for a condition called homocystinuria, which is a metabolic disorder most commonly caused by deficiency of an enzyme called cysteine synthase. So this is the enzyme that is deficient. And let's break down this cycle. So the methionine first is converted into S-adenosyl homocysteine. So the methionine is converted to S-adenosyl homocysteine with the help of ATP that is broken down. And the S-adenosyl methionine is a methyl donor for various cellular reactions. And finally, it's going to be converted into homocysteine. So this is an important point in our methionine cycle, the homocysteine. The homocysteine has two pathways to go for, either go and remethylated again into methionine. So S-adenosyl homocysteine here is a methyl donor, and it gives like it's a methyl group, and finally converted into homocysteine. So homocysteine is either remethylated again and converted into methionine, or either go the other way with the help of cysteine synthase to finally be converted into cysteine. So the defect here in the condition called homocystinuria is in the cysteine synthase. So the cysteine synthase deficiency blocks the transsulfuration pathway. So this is a transsulfuration pathway with the help of vitamin B6 as a cofactor and serine. So it is deficient here. So normally cysteine is not essential as an amino acid. We don't need to take it like essentially in our diet. So the consequences of this condition is build up of some products and deficiency of others. So there will be build up of homocysteine, and also there will be build up of methionine. So the homocysteine is blocked to go through this pathway, and all of the homocysteine will go through the methionine synthase pathway to be converted into methionine. So we will have build up of methionine and homocysteine. The homocysteine is a prothrombotic agent that is gonna increase our risk for having thrombosis, for example, MI or stroke. And we will have a deficiency of cysteine. So the cysteine is non-essential amino acids, but in this group of patients that have homocystinuria, cysteine becomes essential. Homocystinuria hallmark is the cysteine beta synthase deficiency and elevated methionine and homocysteine, and cysteine deficiency. And we've got like typical clinical picture for the people who have got the condition. They are always young. For example, our 12-year-old boy, and they will have like thrombosis at this young age. So we will have thrombosis at young age plus elevated like biomarkers, for example, elevated homocysteine and methionine, and the decrease in the cysteine. So methionine, remember, methionine and homocysteine are elevated versus cysteine, which is decreased. So we've got a diabetic teen collapsing after missing a meal but taking insulin, and glucagon reverses his hypoglycemia by binding to liver receptors, activating a GTP coupled protein that mobilize glycogen stores. And the question asked is, what is the K intracellular effector molecule driving this glucose release? And the answer here is protein kinase A. We will start with like glucagon here binding to GBC receptor, and the GBC receptor is like linked to alpha, beta, and the gamma subunits. So after binding of the glucagon to the receptor is linked to alpha, beta, and the gamma subunit. The GTP will be exchanged with the GDP. So the alpha subunits normally like has GDP attached to it. So after the binding of the glucagon to the receptor, the alpha subunit will have a GTP attached instead, and this will activate adenylate cyclase. So this is the K point here. So after activation of the adenylate cyclase, there will be a conversion of ATP into cyclic AMP, and cyclic AMP like increases protein kinase activation. So this is our answer here. So the mediator here is the protein kinase activating. So the cascade of events that lead to protein kinase activation, first is binding to glucagon to the receptor, the GBC receptor that have three subunits, alpha, beta, and the gamma subunits. And through the GS action, there is an exchange of GDP which is normally attached to alpha subunits at the resting stage. After this like attachment, the GTP will be attached instead to the alpha subunits that will like help the breakdown of ATP into cyclic AMP, and the cyclic AMP will activate the protein kinase A. So the protein kinase A action in the hepatocyte is gonna phosphorylate glycogen, phosphorylase kinase. So there is an enzyme called the glycogen phosphorylase kinase. So this enzyme is gonna be activated by protein kinase A. So protein kinase A is gonna activate glycogen phosphorylase kinase, and the glycogen phosphorylase kinase is gonna activate glycogen phosphorylase, and consequently there will be increase of glycogenolysis. So this means the glycogen is gonna be converted into glucose as our like diabetic teen here in the vignette who had like hypoglycemia, and after giving glucagon and binding to the receptor and the cascade of events, the blood sugar increased again through glycogen phosphorylase enzymes that increase the glycogenolysis. So there are like high yield additions here. There are some other drugs that have the similar effect, either, for example, epinephrine. So the epinephrine uses the same GS like protein kinase A pathway in the liver. So this is acted as a backup hypoglycemia response. So like if you have got like hypoglycemia, there will be like counter hormones such as like adrenergic response. So the adrenergic response leads to the production of epinephrine, which has a similar effect to this cascade that we have talked about through the GS protein kinase A pathway. So remember, epinephrine has the same GS protein kinase A pathway as glucagon, and also albuterol, which albuterol is a beta agonist. We have like who mimics this like via GS also, and this explains the hyperglycemia side effect of albuterol. So remember, epinephrine and albuterol both can mimic this pathway, and this is why hyperglycemia is associated with albuterol as a side effect, and epinephrine as like adrenergic response to hypoglycemia. So we've got a 16-year-old boy with Crohn's disease coming to the ER for frequent nosebleeds and worsening bruises on his legs and hip. And he had like non-stop nosebleed recently and large bruises, and his labs shows normal platelets, but both the BT and ABTT are prolonged. And after getting an IV medication, his bleeding and lab values improved. And the question asks, which step in protein processing does this treatment directly target? And of course, the answer here is post-translational modification. So this refers to the action of vitamin K. So here the patient have Crohn's disease, which is a predisposing factor for vitamin K deficiency. So there are risk factors that may predispose for this, such as malabsorption syndromes, including Crohn's disease and celiac disease. And you have to know that gut flora is gonna like contribute to the vitamin K. And if it is like destroyed for any reason, for example, in an adult patient having a long-term antibiotic therapy killing the beneficial flora, or for the newborns who have lack of gut flora, these group of patients will have a decrease in the vitamin K. So anyway, if you got a deficiency of vitamin K, so you will have deficiency of gamma carboxylation of clotting factor 2, 7, 9, and 10 in the liver. So vitamin K is needed for gamma carboxylation of these like clotting factor 2, 7, 9, and 10. So this happens in the endoplasmic reticulum in the liver. So this is a post-translational carboxylation. So this is why we have chosen like post-translational modification. So what we mean by post-translational, after like the protein is sensitized. So the protein synthesis is translational process. So the protein synthesis is the translational process, and after it is synthesized, there are like some modification which are called post-translational modification. So this refers to the gamma carboxylation of this like group of clotting factor, and without vitamin K, these factors are made but remain inactive, leading to bleeding and prolonged BT slash activated BTT. So you have to know that the BT is affected first, and with severe cases, there will be also affection of ABTT. And given vitamin K allows the liver to activate these clotting factors via post-translational carboxylation and quickly reversing the coagulopathy. And giving vitamin K allows the liver to activate this clotting factor via post-translational carboxylation and reversing the coagulopathy. So gamma carboxylation again occurs as the liver in the liver endoplasmic reticulum and is essential like for calcium binding. So this is essential for calcium binding, which is critical for clotting. And the BT is more sensitive to vitamin K deficiency and is prolonged at first, and severe deficiency can also prolong the BTT. And of course, you have to memorize the risk factor, malabsorption syndromes, Crohn's disease, celiac disease, long-term antibiotics, and the newborns lacking of gut flora. This is a 4-year-old neonate who was brought to the emergency department for evaluation of intermittent tonic posturing over the past 3 hours. The parents reported like poor feeding, vomiting, and failure to strive, and it is noted that the baby's urine has a distinct sugary sweet odor. Family history is significant for an aunt who died in infancy of unknown causes. On examination, we've got our infant here having who is lethargic and with hypertonicity and intermittent posturing, and laboratory studies confirmed the diagnosis. The question asked is about this condition results from a deficiency in an enzyme that requires which cofactor, and the answer is thiamine. So the diagnosis here is a maple syrup urine disease. So there is some busway defect here, which is branched chain alpha keto acid dehydrogenase complex. So the branched chain alpha keto acid dehydrogenase is a thiamine-dependent enzymes, alpha ketoglutamate dehydrogenase, and this is a thiamine-dependent enzyme that breaks down leucine, isoleucine, and the valine. So the like isoleucine and the valine, these are like branched chain amino acids. So the conversion of a branched chain alpha keto acids into acetyl-CoA derivatives requires the thiamine pyrophosphate. So thiamine K functions as a cofactor for three chemical enzyme phospho, like branched chain alpha keto acid dehydrogenase and pyruvate dehydrogenase and alpha ketoglutarate dehydrogenase. And on the clinical picture side, the affected neonate will have maple syrup odor, sweet odor, blood seizures, and acidosis, ketoacidosis, metabolic acidosis. It is an autosomal recessive. This condition refers to maple syrup urine disease, and the pathophysiology here is a defect of busway defect of branched chain alpha keto acid dehydrogenase complex. So the branched chain alpha keto acid dehydrogenase complex is a thiamine-dependent enzyme. So, for example, enzymes such as pyruvate dehydrogenase and alpha ketoglutarate dehydrogenase. So these both enzymes is gonna convert leucine, isoleucine, and the valine, which are branched chain alpha keto acids that's gonna break down these amino acids to be incorporated into like the tricyclic acid cycle. So the conversion of the branched chain alpha keto acids into acetyl CoA derivatives requires the thiamine pyrophosphate. So the Simon K function is a cofactor for three critical enzymes: pyruvate dehydrogenase, alpha ketoglutarate dehydrogenase, and the branched chain alpha keto acid dehydrogenase. On the clinical picture side, these patients will have a maple syrup odor, aka sweetie odor, plus seizure, plus acidosis. So this you have to watch for this triad. These patients will have seizures, odor, which is sweetie odor, maple syrup odor, and acidosis. Pathophysiology behind that, which is deficiency of branched chain alpha keto acid dehydrogenase, which is a thiamine-dependent enzyme that breaks down leucine, isoleucine, and valine. And the blocked step here in this disease is the conversion of branched chain alpha keto acid into acetyl CoA derivatives. That these steps require the thiamine. So the treatment is we're gonna give a thiamine trial plus branched chain amino acid restricted formula. So the branched chain amino acid can't be converted to be incorporated into tricyclic acid cycle. So we have to restrict them. We have to give branched chain amino acid restricted formula plus thiamine trial, and so the branched chain amino acid is gonna be increased. There we will have metabolic acidosis, which is ketoacidosis. These patients will have seizures, and they will have characteristic odor, aka maple syrup or like sweetie odor. So watch it in the vignette for any synonyms for this. And if you like, very important here to know that the very important here to know like this branched chain alpha keto acid dehydrogenase complex is a thiamine-dependent enzyme. So the cofactor here in maple syrup during disease is thiamine, and the defect lies in down in the alpha chain, like in the branched chain alpha keto acids conversion to acetyl CoA. So the problem lies into branched chain amino acids such as leucine, isoleucine, and valine. So you will restrict these like amino acids in your diet, in the baby's diet. So you will restrict these amino acids in the baby's diet, and you will give a trial of thiamine as a treatment for this condition. I hope you guys enjoyed our episode for today, and see you in next videos. Thank you.